Today we are going to talk about coronary artery disease. This will include what coronary artery disease is, the statistics, causes, risks, symptoms, prevention, diagnosis, complications, and treatment. Then we will go over a study that details statin therapy benefits in CAD. First, we must define what coronary artery disease is. Coronary artery disease, or CAD, is a disease that occurs when plaque builds up in the walls of arteries. Specifically, CAD is the buildup of this plaque in the arteries that supply the heart itself. As you can see in this illustration, a normal blood vessel allows blood to move freely and easily. However, a vessel with plaque has a much smaller space for blood cells to move through. CAD, a type of heart disease, is extremely prevalent in the United States. In fact, in the United States alone, every 36 seconds, one person dies from cardiovascular disease. This accounts for 655,000 Americans each year, or 1 in 4 deaths. For CAD specifically, this translated to about 365,914 deaths in 2017 per the CDC. While this map represents all heart disease death rates, it is still an accurate representation of the severe problem this country currently faces with CAD and other heart disease. Starting with the lightest peach color with about 100 to 280 deaths per 100,000 people, and the darkest burgundy red representing about 420 to 1,170 deaths per 100,000 people, this map illustrates the death rates by heart disease per county over the 2-year period between 2014 to 2016. The plaque buildup in CAD is the root cause of the symptoms and complications of this disease. The buildup is made of cholesterol and other deposits that adhere and build on the side of the vessel. This buildup effectively constricts the available space for red blood cells to move. The decrease in the movement of these red blood cells thus causes less movement of oxygen to the tissues. If the blockage becomes large enough, it can block the entire vessel, blocking all red blood cells from moving through. This is known as a clot or thrombus. Many risk factors exist for CAD. First, smoking is a major risk factor. The nicotine in cigarettes raises blood pressure, carbon monoxide reduces oxygen carrying capability of blood cells, and it can also damage the blood vessels and heart. Heredity of heart disease can also be a risk factor of CAD. Furthermore, unfortunately, like most diseases, the risk also increases with age simply because the body starts to become less efficient. Another risk factor is obesity and inactivity. Both factors are usually accompanied by high cholesterol, high blood pressure, and sometimes diabetes. High cholesterol is the material that builds the plaques, high blood pressure puts extra stress on the vessels and heart, and diabetes can cause sugar buildup to worsen the risk of CAD. The symptoms of heart disease, like coronary artery disease, are directly correlated to the plaque buildup. When the plaque builds up, it can cause blockage in the vessels. This blockage leads to pain and a feeling of tightness or discomfort. Most commonly, this pain is experienced in the chest, arms, or shoulder. Also, since these blockages limit the red blood cell movement, less oxygen is moved throughout the body. The lack of oxygen, along with the pain, can lead to weakness, lightheadedness, nausea, cold sweats, and shortness of breath. Prevention of coronary artery disease is centered on decreasing or eliminating the risk factors. So, while heredity and age are something patients cannot change, other risk factors can be diminished or at least lessened. For example, implementing a heart-healthy diet, increasing exercise, and smoking cessation are all great prevention tools. Furthermore, while high blood pressure and diabetes cannot be cured, making sure they are controlled with proper treatment also lessens coronary artery disease risk. Several methods exist to diagnose coronary artery disease. First, an ECG or electrocardiogram can be used to measure the heart's electrical activity. Abnormalities in the heart's electrical activity can be an indicator to complete further diagnostic tests for CAD. One of these tests could be the cardiac echo, also known as the echocardiogram. This test works with ultrasound technology to view the heart and the vessels for blockages associated with CAD. Two other diagnostic imaging tools less commonly used on their own are the X-ray and CT scan. The last non-invasive method is a stress test. By measuring the patient's heart rate response during exertion, a stress test can predict blockage likelihood affecting the way the heart responds to exercise. Finally, invasive methods include cardiac catheterization with or without an angiogram. Cardiac catheterization is a process that checks for a blockage by physically entering the arteries themselves. By inserting a flexible tube through a vessel in the neck, arm, or groin and moving the tube through the vessels to the heart arteries, the blood pressure and strength of blood flow from the heart can be measured. At this time, dye can also be administered in order to complete an angiogram. The dye will move with blood and can be captured using an X-ray picture. If a blockage exists, the dye will stop abruptly on the X-ray, known as an angiogram, to reveal the blockage location. The most common complications of coronary artery disease are vascular spasm, atherosclerosis, and thromboembolisms. Typically occurring in early onset CAD, vascular spasm occurs when there is an abnormal and temporary constriction of an already narrowed blood vessel. This usually happens with an external stimuli such as anxiety, cold, or physical exercise. Since this effect is temporary, it usually occurs without obvious symptoms and does not cause permanent cardiac damage. The second complication, called atherosclerosis, is the term used for gradual growth of the plaque blockages. Typically, vessel injury stimulates an inflammatory response, which lays the groundwork for plaque to adhere to and continue to grow. Over time, as more cholesterol passes by the plaque, they adhere and begin pushing further and further into the lumen of the vessel. The final complication is a result of these growing plaques. When a plaque becomes big enough to rupture the endothelium, it becomes a thrombus. At this point, the thrombus can continue to grow and block the vessel at the site of the first plaque formation. On the other hand, if the thrombus breaks free from the vessel wall to travel the blood vessel, it is called an embolus. Thrombi or emboli that block vessels other than those leading to the brain or heart fall into the peripheral artery disease category. Furthermore, thromboembolisms that travel to block the blood supply to the brain cause strokes. However, when focusing on CAD, we are talking about a clot that blocks the blood supply to the heart. When this occurs, the patient experiences a heart attack. The damage the heart incurs is directly correlated to the size of the vessel that is occluded by the clot. Ultimately, when this occurs, the body only has 4 possible resultant outcomes. A heart attack can cause immediate death, death shortly after due to heart tissue death complications, full recovery due to cardiac tissue compensation, or partial recovery if full cardiac compensation is not possible. Obviously, the complications of CAD are severe and life-threatening, so risk prevention as well as treatment options are of the utmost importance. Part of every coronary artery disease treatment plan should include lifestyle changes such as diet and exercise for risk management. Furthermore, we touched on managing comorbidities such as high blood pressure and diabetes to also decrease CAD risk. However, further treatment options exist to help minimize CAD. Along with medication to control comorbidities, patients can be given medications to decrease their cholesterol. One of the most effective treatments is known as statin therapy. The class of statin medications lowers high cholesterol through lipid management. We will explore statin therapy more in depth with a study analysis. Finally, treatment typically includes low doses of aspirin, which are recommended as a daily blood thinner to prevent blood clots. Now we will review a study titled Statin Therapy is Associated with Lower All-Cause Mortality in Patients with Non-Obstructive Coronary Artery Disease. Both groups in this study were selected based on specific criteria to avoid extenuating factor influence. Patients had to have undergone a CCTA or coronary computed tomography angiography between 2007 and 2011. Furthermore, patients were excluded if they were prescribed aspirin or a statin prior to their CCTA or had to have revascularization prior to their CCTA. Those that qualified underwent another CCTA and were excluded if they had 0% stenosis or blockage indicating no CAD or greater than 50% stenosis indicating obstructive CAD. This left the control group of non-statin users with non-obstructive or less than 50% stenosis, CAD, and the experimental group of statin users with non-obstructive CAD. The hypothesis of this study was that patients taking statin therapy with non-obstructive CAD would have a decreased risk of all-cause mortality and coronary revascularization need than patients not taking statin therapy. This illustration shows what a CCTA looks like. A CCTA depicts the vasculature flow of the heart. If the vessels are not bright throughout, as in these images, a clot or obstruction may be present in the arteries. In this study, After adjusting for sex, age, concurrent medication use, and comorbidities, the following results were obtained. On the vertical y-axis is the survival probability for all-cause mortality. The horizontal x-axis depicts the follow-up of 1 through 5 years. As depicted in these results, statin use, represented by the red line, had a significantly better survival probability rate than non-statin users, represented by the blue line, for all-cause mortality. Similar to the first graph, the vertical y-axis represents survival probability. However, this graph represents that probability for mortality and late revascularization. Again, the horizontal x-axis depicts the follow-up of 1 to 5 years. These results show that statin use, represented by the red line, had a significantly better survival probability rate than non-statin users, represented by the blue line, for late revascularization and mortality combined. In conclusion, this study affirmed that statin therapy in CAD patients produced far better outcomes than non-statin users. Not only were the statin patients less likely to suffer from mortality with statin use, but coronary revascularization risk was also greatly reduced. As mentioned before, statin therapy is a cholesterol-lowering method. So, this study confirms the importance of cholesterol lowering in patients with CAD to prevent plaque buildup, worsening, and more severe complications of uncontrolled coronary artery disease. In this illustration is a simplified look at the slow reversing of plaque buildup that statins execute. So while prevention and minimization of CAD risk factors are the most important components to prevent CAD and complications, treatment options are also available to improve outcomes.